Good afternoon. My name is Katie Hubbard. I'm the Wellness Coordinator for Physicians Health Plan, and it's my privilege today to host today's webinar on colorectal cancer screening with the University of Michigan Health Sparrow team from the Herbert Herman Cancer Center. So we're really excited about today's talk. If you have questions at any time or already coming to this talk with questions on cancer screening or treatment for our experts here, feel free to drop those in the chat at any time and we will address those throughout the presentation or at the end. Your audio will remain muted if you are a attendee for the duration of the webinar today. In the United States, colorectal cancer is the third leading cancer cause of death for both men and women. We know that regular screening can really help find cancer early, prevent it even if we're able to get those polyps before they turn cancerous. And obviously it's much easier to treat then. So joining us today, we have some experts. We have Dr. James Herman, Corey Borden, and Joanne Anderson. I'm going to tell you a little bit about them before we go ahead and turn it over. Dr. Herman is celebrating a birthday today, and he is giving up his birthday lunch to join us, and I'm going to go ahead and embarrass him. But we're so grateful for his years and decades of expertise as part of the Sparrow Oncology team. He's been on board since 1983. He's board certified, he's triple board certified, internal medicine, radiation oncology, and medical oncology. Treating all cancer types, Dr. Herman has been instrumental in developing and implementing Sparrow's multidisciplinary oncology clinics. I know a number of patients in Michigan have seen Dr. Herman as one of their cancer team, and he's got quite a reputation for providing exceptional care to patients. Corey Borden is our board certified genetic counselor. She's got a master's of science focused in medical, molecular genetics, and genetic counseling from the Indiana University School of Medicine. She is the only full-time clinical cancer genetic counselor in Mid-Michigan, so we are lucky to have her. Genetic counseling and testing is a major innovation in the field of cancer awareness, care, and treatment. So I'm really excited to learn a little bit more about how that can help us inform cancer treatment, Corey. So I'm really happy to have you here today. And then rounding out our dynamic team is Joanne Anderson. Joanne is one of the elite group of the oncology nurse navigators at the Cancer Center. She helps to guide patients on their cancer journey through therapy and survivorship. She's been with the health system for a number of years, and I understand she's retiring at some point in the future. So congratulations on your upcoming retirement, Joanne. And we're so happy to have this group here today. Without further ado, I'm going to go ahead and turn it over to Corey to go ahead and get started. We are so grateful again for your expertise in this team to be able to help answer our questions with regard to colorectal cancer screening and treatment.
Okay, we'll do our best. Well, let me first see if I can share my slides just for some visual. Okay, share. And okay, can you see it? Great. Okay, so we're kind of all going to pop in and chat about colorectal cancer screening. We kind of just picked some highlight things to discuss today. So to get started, so first of all, we'll try to hit on, what is colorectal cancer? What are risk factors for that? How do you reduce your risk? And how do we screen for it? Okay. Oh. Oh, there we go. Okay. So what is colorectal cancer? Colon cancer and rectal cancer starts in the colon or the rectum. So that's why we kind of generalize colorectal cancer. Most colorectal cancers start on the inner lining of the colon, and those growths that happen are called polyps. So polyps are very common, especially as you get older. Polyps can be benign, non-cancerous, and some can turn into cancer. And usually that takes a long time to do that, but not always. So there's different types of polyps, which I won't discuss today, but when we have polyps during a colonoscopy, we take them out to make sure that they're not cancerous. Okay. Oh, I have to click. Oh. There we go. Okay. So I mentioned, you know, a lot of times colon cancer starts in a polyp and can grow in the wall of the colon. When the cancer cells are in the wall, they then can grow into blood vessels or lymph vessels. And that's when the colon cancer can spread to other parts of the body. So Dr. Herman can hit on more of colorectal cancer treatment, but depending on the growth of that colon cancer depends on what stage a person is when they get diagnosed. There we go. Okay. So some colon cancer risk factors just in general, and these aren't everything, but just to highlight on them. So we consider people who have a high risk of colon cancer, people who have a genetic syndrome like Lynch syndrome or familial adenomatous polyposis or FAP, where the risk to get colon cancer is usually somewhere between 50% as high as like 100%. A moderate risk would be people with irritable bowel disease or inflammatory bowel disease. They might have a strong family history of colorectal cancer. Those people usually have, or a high instance of polyps in themselves or their family. They have a moderate risk. And an increased risk would be people who are obese. They have a diet that has a low fiber, high fat, lots of processed meats. Those things increase the risk of colon cancer, as well as alcohol and tobacco use. There's also things we know that lower the risk to get colon cancer, such as colonoscopy, exercise, having a healthy BMI, having a diet that's mostly Mediterranean, so limiting red meat, limiting really processed meats, and we know aspirin also reduces the risk of both growing colon polyps and developing colon cancer in the general population and for people who have genetic conditions. So how do we screen for colon cancer? There's a couple things I'll highlight. One is a stool-based test. The other is a colonoscopy. So what are those? The FIT test or fecal occult blood test, fecal immunochemistry tests are two of those names you might hear. Basically, those tests check for hidden blood in the stool from the colon or lower intestines. Usually that test is done every year, can be done at home, so nothing you have to come to the doctor for. You just need a special kit to do it. The other type of test is called a multi-target stool DNA test with FIT, or another name people commonly have heard is Cologuard. That's a stool test that looks for certain abnormal sections of DNA from cancer or a polyp cells. They also look for hidden or occult blood. They look for that in a stool sample. So usually we're looking for that because colorectal cancer or polyp cells have DNA changes or mutations. And so those little fragments of changes can be in a stool, and therefore those tests can help find if there's cancer somewhere in the colon or rectum. So what's a colonoscopy? That's a procedure that a doctor uses to look at the inside of the colon and the rectum. So on the picture to the right, just the colon and rectum are kind of highlighted there. Does not look at the small bowel very much, but mainly the colon and rectum because it's not long enough to get through all the small bowel. But it's a colonoscope, which is a long flexible tube, looks through the colon. It's able to biopsy or remove polyps if they're seen. It has a camera on the end, which makes a picture show up like the little screen there on the left of the picture that a doctor looks at to look for polyps or any abnormalities. So there's pros and cons and limits with any type of screening test. Specifically with a stool-based test, there's not a direct risk to the colon because we're not doing a procedure inside the colon. You don't have to do any bowel prep. There's no diet or medication changes. You do it at home, fairly inexpensive, versus the colonoscopy, which is able to look at the whole colon, can remove polyps, which, as I said before, polyps are usually what becomes colon cancer. So by removing polyps, we're actually reducing the risk to get a future cancer. Colonoscopies have to be done usually every 10 years, which I'll mention except for some certain circumstances, versus the stool-based tests are every 1 to 3 years. So have to do those more often. Colonoscopy also can help diagnose other inflammatory bowel diseases like Crohn's disease or celiac disease, etc. The stool-based tests they can miss polyps and some cancers because unless you have the blood or other changes in the DNA in the stool, there still could be a cancer in there that's growing that we don't see if it's with that test. And if you do have a positive, meaning we found something in a stool-based test, you then have to go have a colonoscopy for a diagnostic test to see what's going on. The colonoscopy, you have to do a full bowel prep, which no one likes. Does cost more for a one-time basis, but the stool-based tests are generally fairly affordable and usually covered by insurance, as well as the colonoscopy. Usually there's some sort of sedation, and you'll need someone to drive you home after that procedure. So you might miss a day of work versus not really missing any time off of work or needing someone to help if you have a doing the stool-based test. And there's a small risk because it's a procedure with bleeding, bowel tears, infection, etc. So in general, when do we do these types of procedures? If you're at an average risk, just regular human risk to get colon cancer is about 5%. So usually we now have started the colonoscopies or a stool-based test at age 45. Used to be age 50 for a very long time, but now it's 45 because in general, we've been seeing a trend of earlier onset colon and rectal cancers. So if you have a colonoscopy and we see polyps, based on what the polyps are and how many they are, you usually have a repeat colonoscopy within 1 to 5 years. If there's no polyps, you're good for 10 years. And that's because it usually takes a polyp about 10 years to grow and become cancer. So the thought process is if you have a colonoscopy and no polyps, if a polyp were to grow in that 10-year span, it's not going to become cancer, hopefully, before we go look again. So that's the rationale there. If you do a stool-based test at 45, if it's positive, meaning we found some blood or those abnormal DNA cells, then you have to do a colonoscopy to see what's going on. If it's negative, then again, depending on if it's what type of a stool test it was, you repeat that every 1 to 3 years. If you have an increased risk, so say you have a first-degree relative with colon cancer at any age, they recommend colonoscopy starting at age 40. So that's, or give or take 10 years before the earliest cancer in the family. So if someone had say a colon cancer apparent at age 43, we usually start screening their children or their siblings at age 33, because that would come first. And again, same thing. We see polyps, you repeat it based on the number of polyps. If you don't have polyps, repeat every 5 years in that case if you have a family history. And then again, if you're at a high risk, the colonoscopy, when we start doing that and when we do and how often we do it really depends on the syndrome and the specific gene involved. Because even within Lynch syndrome, there's a variety of risks. Some have much higher risk versus others. So that depends on that specific gene and the family history. And then again, we repeat that based on polyps or the syndrome involved. I will say for increased risk and high risk people, we do not recommend, it's not recommended to do any stool-based testing. Colonoscopy is our gold standard. And because I'm in genetics, have to mention Lynch syndrome, which is the most common hereditary colorectal syndrome. 95% of people who have Lynch syndrome don't actually know they have it. So it's very highly underdiagnosed. But primarily we see the colon, uterus, and ovarian cancers, as well as some other GI cancers. 1 in about 370 Americans have Lynch syndrome. And again, the vast majority don't know they have it. So whenever there's either early onset, so less than age 50 of colon or uterine cancer, strong family histories like multiple generations of cancer, that's when you should probably see someone like me or talk to your doctor to see if screening for something like Lynch syndrome is a good idea. The other thing is here at Sparrow and other medical institutions, we test everyone who gets colon or rectal cancer. We screen their tissue, their cancer, for Lynch syndrome, because that helps with treatment options for their cancer. And it tells us, should we be worried about the rest of the family and how to watch them going forward. So that's something that we do, Michigan Medicine does, as well as other kind of bigger academic institutions. So plug for Lynch syndrome there. Signs and symptoms that we don't want anyone to ignore. So if you're doing your screening, but some of these things happen between them, you still need to go seek medical care. So any changes in your bowel habits, any diarrhea, constipation, or feelings that the bowel doesn't completely empty, if there's bleeding from your rectum, if there's blood in the stool that make it appear really dark brown or black, any abdominal pain, cramps, gas, or pain that doesn't go away or is really otherwise unexplained, or if you have weakness, tiredness, unexplained weight loss, or a lump in the abdomen or rectum, those are things that you need to see your doctor for. There is a tool. I don't use it that often, but for people who really want to get a better idea of what is my risk to get colorectal cancer, the National Cancer Institute has a tool where we can assess a person's risk based on their diet, their lifestyle, their family history. This tool is not for people who have irritable or inflammatory bowel disease like colitis or Crohn's, or genetic conditions like FAP or Lynch syndrome. It can be used in patients of non-white or European ancestry. It's just a little bit more limited because we don't have as much data from those other groups, but can still be used, and it's not for anyone less than age 50. So anyone over age 50 who wants to kind of just take a quiz to see, what is my risk to get colon cancer based on all those factors, that's a good place to go. So here's all of our contact information, but I'm also going to turn it over to Dr. Herman to talk about more colorectal treatment that we have going on here at Sparrow.
So, like Joanne said, that was an overview of colon cancer in 10 minutes. It's not quite as easy as she made it sound, but the important things to take away from that is that there is a way to find cancer early. So the whole push in colorectal cancer is to find an early cancer, because early cancer translates into curability. So curability for, say, a stage 0 or a stage 1 cancer is vastly different than if you present with the stage 4 cancer. Even stage 4 cancer is being transformed into longevity these days because of the treatments that are available. But early detection is the key in colorectal cancer. So besides all of the risk factors that we know about, the most important thing is to also be vigilant in regards to your symptomatology. So if you have a negative test, but you have symptoms, you still need to seek medical attention. Medical attention and combined with the screening programs will help detect early cancer. If you have very early cancer, all you may need is a surgical approach, and that will cure you. If you have more extensive disease, then treatments can involve chemotherapy, immunotherapy, and radiation. So it's really based on your stage of disease as to the extent of treatment that you require. Colon cancer overall in the early stage can be close to 100%, whereas even stage 4 now is about 50% at 5 years for locally advanced or metastatic colorectal cancer. In fact, recently, people have been living 5 to 10 years with stage 4 disease being aggressively treated that was not even heard of 5 to 10 years ago. So there's a lot of options for colorectal cancer that were not available before. In regards to screening, the gold standard, as Corey said, is a colonoscopy. Everybody hates colonoscopies, not so much the procedure, but the prep. And I must say, in personal experiences, the prep has vastly improved over the last 20 to 30 years as compared to what it used to be. But you have to use that in regards to what are you trying to accomplish, and that's to cure your cancer if you have one. So colonoscopy remains the gold standard. However, there are the stool-based tests. The stool-based tests, as Corey said, blood in your stool can be from colorectal cancer, can be from other things, but if you're positive, that leads you to a colonoscopy. Of course, we hear very much about Cologuard because they have large budgets that are on TV all the time, mostly around the news, I might add, because I think that must be the population they're targeting. So Cologuard is a test in which you study not only the blood, but also the DNA. and the DNA changes in the cells that are shed into the stool help decide whether that's significant or not. Does that mean if you have a Cologuard positive test, you have cancer? No. It means you bought a colonoscopy follow-up to prove one way or the other whether you have cancer or not. So my few takeaways are that if it's early, highly curable, limited treatment. Even if it's advanced, very good outcomes available. So I would urge everybody to get their screening. The other point I want to make is previously we used to screen at 50, but we've been seeing an increasing amount of young people with colorectal cancer. So even though we're recommending screening at 45, people who have changes in their bowel habits or blood or the things that we listed are really not to be ignored. Because even though you think, oh, well, it's an old man's disease, well, not so much anymore. We are seeing people even in their 20s with no predisposing factors have cancer. So I would urge you to pay attention to your bowel habits. Now, not every minute of every day, but at least pay attention if you're having any of the symptoms that we talked about. And I'm happy to answer any questions.
Joanne, do you want to tell them what you do?
Yeah, my role is I'm the nurse navigator for the colorectal multidisciplinary clinic. So I normally, my first encounter with patients is usually when they've had a diagnosis. But I'm available, and my contact number is listed on the slides. Corey put it on there. So if you have any questions or you're facing any barriers to finding how to get a colonoscopy, you can welcome to give me a call and I'll help connect you with some resources.
So I guess we're open for questions if there are any. We can't hear her.
We can't hear you, Katie.
Thank you. So I'm curious, if I go in for a screening colonoscopy and they find polyps, are they able to biopsy them then, or would I have to come back for a diagnostic colonoscopy?
No, you should be able to have the colonoscopy. If they find anything abnormal, they will biopsy them. Sometimes they'll even remove it in totality during the colonoscopy so that it's a one-stop shop.
That's quite ideal.
Yes.
Corey, if patients are curious about their genetic risk with regard to cancer, let's say they have a strong family history, is there a way for them to be able to meet with you, or is that typically only after they are diagnosed with cancer to inform their treatment?
Yeah, so I meet with both people who have cancer and they have a strong family history, or they're young, or we need genetic testing for treatment purposes. And also people who are just worried about their family history. Maybe people have passed away and they don't we don't know if it was genetic, so they get referred to me by their usually family doctor, OBGYN, maybe their colon gastroenterologist, or anyone else. They can self-refer, yep. Just based on their family history, to have a conversation and take a more thorough look and see what's going on, if we need to be worried about it or not.
Makes sense.
Okay, I see a question there from Dennis. Are the insurers like PHP supportive of annual or biannual colonoscopy schedules for older or high-risk hereditary candidates? Great question, Dennis. Katie, you work for PHP, so just maybe ignore what I'm about to say. But I do have the blessing from all the colorectal surgeons that all my patients with Lynch syndrome in particular, it's actually been quite tricky for them to get, usually they need to get a colonoscopy every 1 to 2 years based on if they have polyps or not. And that goes forever. For many people after age 75, we start weighing pros and cons of doing colonoscopies. But if you've got Lynch syndrome, again, we're doing that, forever. So it is not well approved I would say. And so what I tell my patients and what the colorectal surgeons have given me okay to do, and they do, is that, if you need another screening colonoscopy within a year or within 2 years, you can just go to your doctor and tell them you have rectal bleeding. You don't have to prove it. And it can be on, the 2 years prior to your last scope, but that buys you a diagnostic colonoscopy, which then does get approved almost always by insurance. So unfortunately, insurance companies really like to not exactly follow, especially our hereditary colo screening recommendations and for other cancers too. So we do have to jump through a lot of hoops usually to get those screenings covered. So rectal bleeding is the way to get your colonoscopy, Dennis.
Yeah, Dennis, I don't have anything to add. If you have specific questions, I'm happy to reach out to customer service for you with regard to your own, if you have like the specific instance in mind. But as far as annual colonoscopy schedules, I do not know. But if you want to shoot me an email, you'll get an email from me next week with, the recording and the PDF of the slides. Feel free, we can continue the conversation there. Are there any other questions?
Though, I would just like to add, if you are asking about routine colonoscopy for anybody over 45, that is usually recommended and recognized as a screening procedure, and it is covered by most insurances.
Yep.
And if it's not covered, there are ways to get your colonoscopy no matter what.
Yeah, that's part of the preventative services schedule. So
Right.
that screening colonoscopy. Now, the tricky thing is if you have a screening, let's say you do Cologuard for your screening, and then it finds blood in your stool and you get a positive result, and then you have to go back for a diagnostic colonoscopy,
Correct.
which is going to fall under a different bucket.
Yes, correct.
So,
Yeah.
this was really helpful. You mentioned Mediterranean diet and maintaining good health as far as like diet, exercise, regular, not smoking. Are there other specific risk factors for colorectal cancer that are modifiable?
I think I have a lot of patients recently who have a lot of inflammatory bowel diseases like Crohn's and colitis, and those are very hereditary. So a lot of people have a family history of them, and it could present differently in people, and that goes with kind of autoimmune conditions. So that being said, being aware of what those flare-ups could be like, especially for, kids, siblings, so that they can go in and get treated and then get those managed, because with the inflammatory conditions, they've got a higher risk of colon cancer too, but it's a different process for how cancer develops with those conditions. So the most important thing is keeping everything not inflamed. So that could be diet modification. The gastroenterologists are the best people to help with that. That could be medication. But for the general population, yeah, as we said, lots of fruits and veggies, fish versus red meat or limiting red meat, anything with lots of fiber, aspirin, if you're able to take aspirin, a daily aspirin, which there's been studies between a baby aspirin and a full aspirin. And for people who have Lynch syndrome, we actually do like a lot more aspirin. So that can also reduce the risk if you have no other bleeding issues or other concerns by your family doctor to take that. So otherwise, yeah, just being active, having a healthy BMI and a lower fat diet those are all good things to do. But people, if you live long enough, as I tell patients, stuff happens to you, and you can be the healthiest person in the world, and you're still going to get cancer someday. So you can just do your best and hope you don't get it, and do your colonoscopy screenings, which again reduces the chance of getting it because we take out those polyps. So colonoscopy for everyone.
Yes, I love it. Did you see the question about the dosage recommendation?
What are the dosage recommendations for aspirin? So there's been a variety of studies, both with a baby aspirin, which is 81 milligrams, up to a full dose, which is 325 milligrams. So I would talk to your family doctor and see what they're okay with you taking, if that's okay for you to take aspirin. Some people can't take aspirin for a variety of reasons, and it can be hard on your stomach. So kind of playing with, what works best for you. But we also see that as a prevention for people who have had colon cancer to reduce the chance of future colon cancers. Aspirin has been proven to do that. And again, especially for Lynch syndrome, huge risk reduction. If you take aspirin, I think the stats are for like 4 years, when you have Lynch syndrome, it reduces the risk by almost 60% to get a colon cancer. So in the general population, it's more like 10 to 20%, depending on the study. But that's also something you could definitely talk to your family doctor about.
Awesome. Well, thank you so much for your help and your expertise and sharing with us, Dr. Herman and Corey and Joanne. To everyone else, thank you for joining us. I hope this was helpful and informative, and we'll look forward to seeing you again.
Bye-bye.
Thank you.
Thanks, guys.